Complex oxygenation. So think about being in the ICU and understanding the importance of your nursing career or care to that patient and what things we are going to be looking for. Our chapters are 26 and 24. Again, be mindful of those pages so that you're not overdoing it. Our concepts that we will look at are pulmonary embolism, pleural effusion, acute respiratory failure, acute respiratory distress syndrome, our ventilators, and chest trauma. I do want to emphasize that not all hospitals provide a respiratory therapist for every unit. I have worked in some hospitals that provide a respiratory therapist that's paired with a nurse. But that's not going to be everywhere. Some hospitals have one respiratory therapist for the entire hospital. So, why am I saying this? Because when you have your own respiratory therapist working with you with the same patients, and your patients are on ventilators, it's very helpful because they kind of step in and help you with your ABGs and your ventilator status. Now, if you do not have that respiratory therapist, even if you do have that respiratory therapist, you still need to know about the ventilator and the importance of different sounds, what to be looking for, location that it's placed, all of the important stuff so that you can prevent your patient from ultimately going into a complication and possibly death. And then we'll touch on chest traumas. So when we look at respiratory issues, we have to understand what is happening. Is it because the alveoli are not exchanging gas? Is it a ventilation issue? So is oxygen not able to be exchanged for that CO2 so that we can breathe it out? Or is it that we're overdoing it with the oxygen? We're giving them too much oxygen. Remember, your COPDers can't tolerate high amounts of oxygen. So if we give them too much, it kind of blocks things off and then they become toxic. Or there's another one, is it perfusion? Remember, our cells need to make ATP for us to stay alive. In order to make ATP, you have to have components of oxygen and glucose on we call it a Krebs cycle, on a continuous exchange, and for the waste component for the oxygen and glucose. And ultimately, if we do not have that, the cells are going to die off. So that would be your perfusion. So things that we'll cover is the lung, the pleural space, vascular inside the lung, and vascular outside the lung. So things that we need to be aware of when we're assessing our patient. If you ever feel your patient and you start to hear that snap, crackle, and pop, the Rice Krispie sound, that is sub-Q emphysema, subcutaneous emphysema. So you can touch them and you can it feels like Rice Krispies on them. That means that air is being trapped under the skin. So it's typically from like a collapsed lung, an esophageal tear, something complicated and dangerous. So you must call the medical doctor. The other thing that we can look for is frematist. So when you were doing your head to toe and you had that component where you took the back side of the side of your hand, like it is in this picture right here, and you asked the patient to repeat 9999 as you kind of tapped on their back, you should hear some vibration in their voice when they're repeating that 9. However, if they have fluid buildup or air building up because of a collapsed lung or pneumothorax, they can no longer say 99 or 9, or they're saying it and there is no vibration. That means that there's something trapped in there. They don't have the ability to have that vibration. So that would be an important finding. Pleural space issue. So when we look at our lung, we have this nice little pleural space. It's like a lining that protects the lung. It has some serous fluid in there. And that is just so that our lungs can inflate and deflate without rubbing against other tissues. The problem is if your patient gets some kind of cancers, if they get a stab wound to the chest, if they have a history of any type of air accumulation in the wall, the pleural space, that pleural space can be damaged and it can collapse the lung. So we see here the pleural space here is filling up with air. So that is going to create a pressure to collapse the lung. Now that patient's not going to be able to breathe through that side, which is a bad thing. Over here we have a hemopneumothorax. So we have blood down here and we also have air. And then we have a hemothorax, so it's just blood. There are several different types of pleural space issues. But we're going to focus on air, mostly air. So we look at a pleural effusion. Well, I lied. We're not looking just at air. We're going to be looking at fluid accumulation in there as well. So when the fluid fills up in that pleural space, we have a pleural effusion. You see how the fluid is pushing up on that lung. So that lung's not going to be able to expand completely. Your serous fluid, it could be exudates, which is serous fluid plus blood, which is typically from like an infection. But it can happen from lung cancer, tuberculosis, renal disease. Remember we learned about acute versus chronic conditions, and that can affect your lung over time because the diaphragm gets pushed up and all the creatinine, the nitrogenous waste, irritates the tissues. And then liver failure, same thing, ammonia builds up. How do we diagnose? Well, your patient's going to be complaining of shortness of breath. They are going to probably be complaining of chest pain. But how do we truly diagnose it? We're going to get visualization of that lung. So CT scan or chest x-ray. Medical management. We want this fluid out. So we can do a thoracentesis where it's on the next slide, where they go in with a large bore needle and they remove fluid. Now, what do you do with that fluid? Do you just toss it away? No, you have to send it to the lab so that they can do a pathology report on it. See what the problem is. What's in that fluid? Maybe they need a different antibiotic for their pneumonia. Recurrent effusions. So if this effusion keeps occurring over and over and over again, your patient is likely going to need a chest tube. That chest tube, hopefully you guys have had the opportunity to look at them in SimLab or just lab in general and mess with them. We're going to touch on them a little bit, but that's going to allow either to be hooked up to suction to drain it out, and it also creates a seal. Fluid removed is assessed and then sent to the lab. Always make sure some components of that fluid are sent to the lab so that we know what the problem is. So this is a thoracentesis. We have the patient bending over, and they're going to go probably into the lower lobe where that fluid is accumulating. It just depends on where the fluid is. Hopefully relaxed, maybe giving them something to relax them, and then they're going to pull back on that syringe and that fluid is going to accumulate. So we see here it's in that pleural space. So vascular issues of the lungs. Our capillary beds surround our alveoli, and that is where we exchange oxygen for CO2 so that we can breathe out that CO2 or carbonic acid. Vascular perfusion. Oxygen issues can occur due to clots in the vessels. So a DVT or pulmonary embolism. So a DVT with a PE is called a venous thromboembolism, a VTE. We can see here we have some clots. Now at the end of these we have alveoli building up everywhere. Now, if we have a clot, we're blocking the vessel and no oxygen or waste product is getting through. So that patient's not going to be able to perfuse. Their cells are going to die off, and it's going to be a big problem. Looking at a pulmonary embolism, it is an occlusion of an artery in the pulmonary system. So what is happening? Air is moving, but blood flow is not picking up the oxygen to deliver or drop off that CO2. So when we breathe in, we're breathing in that oxygen, and hopefully our alveoli are exchanging that for that waste product of CO2, the acid, and then we can breathe it out. However, if we have a pulmonary embolism, it's going to stop. There is going to be no gas exchange. Why is that important? Because you get a buildup of CO2 and you don't get any oxygen, so your cells won't live. Depending on the size and location of the occlusion will indicate how emergent the situation is. Now think about how a patient, they get that thrombus, typically in their body somewhere, and it travels through the venous system, goes in through the right side of the heart, and then it's going to get trapped in the lung. Why the lung? Because that's where most of the small vessels lie. When you think about the pathway of blood flow, it's likely going to get trapped in the smallest vessel, and that tends to be the lung. Now, if it bypasses the lung, then we can worry about the left side of the heart and it getting trapped in the coronary tissues. However, you're more than likely going to see a PE if you have a body thrombosis. So a thrombus is formed, it causes an occlusion, and when it breaks off, that becomes an embolism. Occlusion can be made of or thrombus, embolism can be made of many different things. So it could be blood clot, it could be air. One of my students not that long ago said that they watched a nurse not prime their tubing and that they hooked it up and just started it. So think of all that air going into that patient's vessel. That could be an air embolism. We like to say air embolisms can be possibly from something like that, injection of air into the vessel, and it's typically anywhere from 50 to 100 milliliters that can kill a patient, just dependent on the patient. But it's always very important to make sure you prime your tubing. It could be a fat embolism. So fat embolism, think a break in one of your large bones, typically like your femur. Patient gets in a motor vehicle accident, breaks their femur, they're at high risk for fat emboli. And then your amniotic fluid when you're pregnant. So occlusion can be seen with air entering the venous system, so your air embolism. Things that you will look for with any of these embolisms: shortness of breath, decreased oxygen saturation, chest pain, anxiety, air hunger, dyspnea, decreased level of consciousness because we're not getting the oxygen to our tissues. And then our heart's going to try and compensate by beating faster. So always make sure you prime your tubing. Complete or partial obstruction can occur. So you can have a partial obstruction and have mild symptoms. But what happens when we have a partial obstruction? Our body it's going to start to build up with platelets and become possibly a complete obstruction. Increased risk with prolonged bed rest, your patients that are not getting up and walking around, especially post-op. It is priority if they are a candidate to ambulate, to get them up and ambulate. If there are oncology patients, they're a high risk. If they're just not moving, they are a high risk. Think about being on an airplane. Let's say you're traveling from Texas to Australia. If we are not getting up and walking, and we're a high risk already, maybe we're morbidly obese and they smoke and they have a history of clots, being on that airplane for such a long time, sitting, not moving, is going to put that patient at a high risk for embolism. And it is pretty lethal. Depends on the amount of occlusion and location. So how do we prevent? Passive and active range of motion for all post-op and immobilized clients. Things to remember, if they do have a history of embolisms or thrombus, we try not to elevate their head of the bed above their chest, so don't put pillows under their knee. That's going to prevent pressure under that popliteal space. Instead, we are going to get them an air mattress. And the new thing that we see in the hospital now is the sand mattresses. Those are good. Make sure your patient is getting up out of bed as soon as possible if they are a candidate. SCDs, those are very important. They help with pressure. So Pexi Pulse uses variable pressures where your SCDs use consistent pressures. We don't want things just sitting around. We want that blood to be moving. Client repositioning every 2 hours. Low dose anticoagulants and antiplatelet medication. So your Eliquis, your warfarin, heparin, Lovenox, even your aspirin, your baby aspirins. Smoking cessation, so especially with females on birth control, always remember estrogen and smoking equals clots. We do not want that. And of course, we always want to avoid our risks for building a thrombus. So that's your Virchow triad. Endothelial damage. How do we get endothelial damage? Endothelial means the inside of the vessel. How does that become damaged? And it could be chronic hypertension, not caring for it. It could be plaque buildup, so high cholesterol. Anything that's going to injure that vessel wall. The second part is venous stasis, so not moving, not causing blood to, if blood just sits there, it's going to coagulate. And in the hypercoagulable state, so some patients unfortunately have, you'll hear them say, I have thick blood. This is pretty much what they're saying, that their clotting factors are, there's too much of them. So expected findings of a pulmonary embolism. Your patient's going to have sudden onset of shortness of breath. So dyspnea, and they're going to be anxious, they're going to have lots of apprehension and feeling of impending doom. Anytime your patient is having a condition that is going to cause high risk for mortality, they are going to be so fearful and tell you, I feel like I'm going to die. And they're not lying to you. Pleuritic chest pain. So that means there's chest pain specifically in that pleural space. It's going to be sharp. It's going to be stabby because it's not getting oxygen. Pleural friction rub. So as the tissues become inflamed from lack of oxygen and a buildup of CO2, that pleural space is going to start rubbing together. And we can hear that because of the pleural space rubbing together is inflamed, and we can hear that when we listen to them. You can actually hear like a rubbing sandpaper sound. You can also hear crackles as fluid is not moving the way that it should. It starts to build up in the lungs. Hypotension, so they're going to be tachycardic and have low blood pressure. What does that sound like to you? Like shock, right? S3 or S4 can be heard. Remember, we don't really like hearing those extra sounds in our heart tones. Hemoptysis, patient coughing up blood. And then petechiae. Petechiae across the chest and the upper body. So we can see here they have a clot. It doesn't even look that big, but imagine how small those vessels are in your lung. It's not going to take a huge clot. In our diagnostics for pulmonary embolism, so we definitely want to get visualization in there. CT is probably going to be the best. That's going to allow you to look at the actual blood flow. For a chest x-ray, you could probably see fluid accumulation, things building up in the chest. We can do an MRI or an MRA. to look at the arteries. And we're definitely going to pull a D-dimer. Remember, D-dimer tells you if it's elevated that there's a clot somewhere. It doesn't tell you exactly where, but if the D-dimer is high, think clot. There's a clot. Something is happening. We can also do an ultrasound, but ABGs, D-dimer, and CT are probably your best friends for your lungs. So ABGs, what does that tell you? If there's gas exchange, is the acid building up, or do you have too much bicarb going on? What is happening? So respiratory alkalosis, you are breathing out all of that CO2. So breathing really, really fast, hyperventilating. This is typically triggered by hypoxia. You're also, so at first they could be alkalosis because they're hyperventilating, they're freaking out. And then as the PE continues, they're going to start to retain that CO2, not breathing so well, and they turn respiratory acidosis. Now, what happens when we have respiratory alkalosis or respiratory acidosis? What organ is going to pick up the slack? And that's going to be your kidney. So if we have too much acid in our body, what does our kidney do? It starts to retain the bicarb and get rid of their acid. So you could go, if you're respiratory acidosis later on, it could be alkalosis. However, in that when they first present to you, they're going to be alkalosis. So eventually, if they continue down that road and they continue to have cellular death, that's going to lead them to metabolic acidosis, where the lactate spills out of the cell that's dying off. And what are you going to see? You're going to see a buildup of hydrogen ions or acids. Nursing management for your pulmonary embolism. Treat the hypoxia, of course. So elevate the head of the bed. Anytime your patient is having struggling breathing, we never lay them flat. We set them up. Monitor their level of consciousness. Listen to their lung sounds. From hypoxia, they're going to be hypoxemic, where now their blood doesn't have oxygen. So you'll see sudden shortness of breath, chest pain. This is when you're calling the rapid response. Give them oxygen. Raise the head of the bed. You can also see hypotension. So if they start to be hypotensive, they're vasodilating, thinking if I vasodilate, oxygen is going to get to the tissue. But it's not, because you're not able to get past that embolism. So we're going to monitor for urinary output. What's that going to tell us? If our kidneys are no longer being perfused, then that's going to create a kidney injury. Make sure that patient's not smoking. Make sure your patient's not on birth control and smoking. And of course, we're going to get the, just depending on what the situation is, make sure that there's heparin on board or some type of fibrinogen. So heparin, you're going to need IV access. Hopefully you've already got that. It's going to be given by a drip. Make sure you implement bleeding precautions and you're monitoring your APTT. But ultimately, they need something that is going to prevent further clotting or break the clot up. Now, what is our antidote for heparin? So if we give them too much heparin, they bypass the therapeutic threshold of their APTT. Then we worry about them being way too big of a bleeding risk. So we're going to give them protamine sulfate. That's the antidote. Heparin is typically given for 5 to 10 days. And we can also start them on their discharge protocol while they're still on heparin. So that could be your warfarin or Coumadin. So that they maintain therapeutic range and we know that they're stable to go home. We have to monitor their PTT. Enoxaparin, that's your Lovenox. Warfarin, this is what they're likely going to go home on. Things to remember though is warfarin is super, super cheap, but they need follow-up. So if you're a patient, we know that they're non-compliant, this may not be the best drug of choice for them. Remember, the antidote for warfarin is vitamin K, so like green leafy vegetables are probably not the best go-to, not in abundance. If they do eat too much vitamin K, fresh frozen plasma, we could give them. Monitor your INR, PT-INR, and this is where complications can occur because your patient may not be following up with that. Oral anticoagulants are taken typically for up to 6 weeks, and they're probably getting a PT-INR at least weekly to make sure they're in a therapeutic range. Those are your big ones. Don't forget your TPA and the protocols for your TPA, like who can get it, who can't get it, because it is an embolism. They could be a candidate for getting TPA, but if they've had a recent surgery or a recent stroke or any of those things, then they can't get that TPA. Medical management, make sure you're sitting them up in a high Fowler position, applying oxygen, reassuring the patient, not panicking with them, assess respiratory and cardiac status. We're looking for petechiae specifically on the chest, making sure they're on anticoagulants. We're assessing for bleeding and putting them on bleeding precautions, especially if we've started that heparin drip. Now, things to be concerned about with giving heparin is heparin-induced thrombocytopenia, or what we say HIT, in the hospital. It is an immune-mediated response to heparin. So you give the heparin, and then their immune system's like, what is happening? I'm going to start to attack all of this. So it's an unexpected drop in platelet count or platelet destruction after heparin therapy is initiated. So it can occur with any type of heparin. It is more common with the unfractionated heparin or your heparin drips. Our risk factors, who would be a higher concern for HIT? It would be your female patient that they had heparin for over a week prior, previously on heparin within the last 100 days, and have a history of bleeding disorders or issues. So let's say your patient had some kind of maybe they had the gallbladder removed. And maybe the surgeon accidentally did something, and then all of a sudden they get a pulmonary embolism. But prior to this gallbladder removal, they were on heparin 2 months ago for something else. So, but now, total different scenario. They're in the hospital because they got the gallbladder removed. Now they have a pulmonary embolism, and now they're on heparin. Remember, they had heparin 2 months ago, and now they're on heparin again. It's a female. Well, she starts to have signs and symptoms of bleeding everywhere, of shortness of breath. Then we're going to really be concerned about heparin-induced thrombocytopenia. So, risk factors: female, previous history of being on heparin, in a history of bleeding disorders. Remember, you're going to see a massive drop in platelet count or platelet destruction because it's an immune response. Clients with HIT still need to have that anticoagulant though. So does that mean that we're going to be giving them the heparin? No, because that immune system reacted to it. So we got to change it. A lot of times you'll see bivalirudin given, or your Angiomax. And why we do this is because your body destroys all the platelets all at once, and now we have no way to clot. But we still have those little microclots because you were already building those clots. So small clots are going to occur, and that can also cause some issues. Nursing, you're going to watch for GI bleeds. You're going to monitor your hemoglobin, hematocrit, your platelet count, looking for oozing IV sites, bleeding gums, bruising, petechiae, all the bleeding concerns. So heparin-induced thrombocytopenia, where you have subclots that all of a sudden you your body starts to overreact, uses up all your platelets. So now you have no more clotting factors, and now you're a huge bleeding risk, but now you have all these little microclots everywhere. So there's an immune response. You get heparin, anticoagulant medication preventing clots, but now all of a sudden you have a decreased number of platelets because your body killed them all off. So not only you have little clots, you have bleeding issues. A nurse answers a call light and finds a client anxious, short of breath, reporting chest pain, and has a blood pressure of 88/52. What action by the nurse takes priority? So, we have an anxious patient, short of breath, with chest pain. These are all signs and symptoms of a pulmonary embolism. Now we look and we have hypotension. I bet their heart rate is really high. So our answer, would we assess the lung sounds? No, we're way past that at that point. Yeah, we will be assessing them, but our priority is to get help, have other people with us. So your answer is B. Provide reassurance to the client. We're going to absolutely do that. Take a full set of vital signs? Absolutely. We're going to do all of these things, but our priority is going to be notify the rapid response team. A client is admitted for a pulmonary embolism. The client is young, healthy, and active. Has no known risk factors for a pulmonary embolism. What action by the nurse is most appropriate? So we know that the patient has a PE, and it has no history, like they're a low risk for having a PE, but that's why they're admitted. So are we going to have that patient walk? No, especially for 5 minutes every hour. They're going to be so short of breath. No. Refer the client to smoking cessation classes. I mean, maybe if we know that they're smoking, but this client's healthy. We're going to assume that they're not smoking. Teach the client about factor V laden testing. What is, sorry, factor V. Factor 5 laden testing. Yes, absolutely. Teach a client that sometimes no cause for disease is found. We're not going to say that. If that is true, then the doctor's going to say that, not us. So factor 5 is an inherited thrombophilia that can lead to abnormal clotting events, including pulmonary embolism. So we know that the client is healthy and young and also active. So we need to consider that it is a coagulation pathway issue. So maybe the factor 5 is abnormal and now they're building up clots. A client is on IV heparin to treat pulmonary embolism. The client's most recent partial thromboplastin time was 25 seconds. What order would the nurse anticipate? So, what's a normal PTT? A normal PTT is 1.5 to 2.5 times the normal value. What's a normal value? Well, that's 25 to 35 seconds. So we have IV heparin on board, and they still have a normal PTT. So that means that they're bleeding at normal rate. If we're on heparin, we want them to bleed a little bit longer. So we want them to bleed for 1.5 to 2.5 times 25. The easiest way I remember how to calculate your PTT is I always remember 30 is normal. And if they're on an heparin, we want them to bleed longer, so 2 times 30 is 60. We want them bleeding for 60 seconds. So they're not at therapeutic range. So would we decrease, increase, not change, or stop? Well, we want to decrease it because we want them bleeding longer, so they need to have more. So we're going to increase it. Or have the doctor increase it, sorry. Respiratory failure. What is respiratory failure? Um, Ultimately, it is the respiratory system not doing what it's supposed to be doing or meeting the body's the need for their oxygen delivery. It can be a ventilation issue, so maybe there's something going on with the alveoli and the capillary bed surrounding the alveoli where there's no gas exchange, or maybe you can't get oxygen in, so an oxygenation failure, or maybe oxygenation can't be perfused. So the causes of it, decreased respiratory drive. What causes decreased respiratory drive? So that could be your patient overdosing on an opioid. Obstruction of airway. What would be an obstruction of an airway? That could be your COPD or having a mucus plug or asthma, trauma. Injury to the lung tissue or chest wall. So think gunshot wound, think blunt force trauma to the chest, dysfunction of the chest wall. So when I think of dysfunction of the chest wall, I think of an anatomic malformation on that body. So maybe the patient has scoliosis, maybe they have sleep apnea where they're really morbidly obese and their chest wall can't move as well. Maybe they have broken ribs and they don't want to take deep breaths. So some disorders could be sleep apnea, pulmonary embolism, overdose on CNS depressants. So our clinical findings, early findings of respiratory failure. What happens when our patients aren't breathing so well? This is one of the first things that we will notice is they get restless, they're irritated, and they're typically a very sweet patient, but now they're just they're just constantly pushing that collate and constantly just like, oh, something's wrong. They're going to complain of shortness of breath. So what do? We got to sit them up. Remember, you got to sit them up. Late signs, this is where maybe we weren't being the best nurses that day and we ignored our patient. You walk in that patient's room, they're going to be lethargic, maybe even not arousable. They're going to have cyanosis. Central cyanosis is like their truncal area, and respiratory arrest where they're not really breathing at all. And then, of course, we're going to look at our ABGs. So respiratory acidosis means your patient's not bringing oxygen in and they're not breathing CO2 out. So their oxygen saturation is going to be less than 60, arterial oxygenation less than 60. Our oxygen saturation pulse ox is going to be less than 90%. Unless there's COPD, remember your COPDers can run in the 80s and be fine. Our CO2 is going to be elevated. They're retaining all of that CO2. And then the pH is going to be acidic, so a low pH. So hyperventilation equals respiratory alkalosis, and hypoventilation, which is your respiratory failure, is respiratory acidosis. Now, our nursing consideration. What is priority for your patient that is in respiratory failure? Oxygenate. Give them oxygen. Sit them up. Then you're going to monitor their level of response. Make sure you're frequently checking those vital signs. Anticipate that they're going to get intubated, but we don't just jump into intubation. We're going to go from least restrictive or least invasive to most invasive. So least invasive is sitting them up, giving them oxygen. The next step could be putting them on high flow or a non-rebreather. The next step could be CPAP, BiPAP. And then the next step would be intubation. Now, that is in a perfect world. That is not necessarily what you will see in the hospital. If our patient is already turning blue, and they're in the ER and they're non-responsive, then yes, they're probably going to be ventilated. But if they're up on the floor and they start to respond to that 2 liters of oxygen, we're not going to intubate them. So monitor for level of response, get your vital signs, make sure you're on continuous pulse ox, and getting your ABGs. That is going to tell you that there is gas exchange occurring. Prevent ventilator-associated pneumonia. So when your practitioner and your doctors or residents are intubating, it is supposed to be a sterile technique. However, that is not always going to happen. Sterile technique, we all know, is very complicated and hard sometimes. When you're in a true medical emergency in the ER, we're hoping that we maintain that sterile technique, but our priority is to get an airway established in that patient. So we want to prevent ventilator-associated pneumonia. It also is the suctioning, making sure suctioning after they've been intubated and on a ventilator, that we're preventing all of this stuff. Peptic ulcer prophylactic. So your patient that gets intubated on a ventilator needs to have a H2 blocker or a PPI on board being given to them. When your body is in high stress, physiologic stress, your body secretes massive amounts of cortisol. Cortisol is going to break down your stomach lining. And Lord forbid they get a peptic ulcer and it perforates while they're on a ventilator. That is the worst case. You don't want that to happen. Venous thromboembolism prophylactic. If they're on a ventilator, they're probably sedated a little bit, so they're not going to be moving. Head of the bed elevated 30 to 45 degrees. Chest physiotherapy, where we're shaking them up a little bit, loosen up that mucus. Humidification, adding some moisture to it, so it helps with breaking up that mucus. Suction as necessary, don't over suction though. Have effective coughing, and monitor fluid intake to allow for secretions to be coughed up. Respiratory management. So increase oxygenation. Always start with oxygen via nasal cannula and then steadily move up in invasiveness. Intubation, we can do mechanical ventilation. That patient's going to be in the ICU. We're gonna try some bronchodilators at some point, antibiotics at some point, anti-inflammatories, and steroids. Now your ARDS, your acute respiratory distress syndrome. I will say this patient, you'll see them in the ER and go straight up to the ICU. So what is the definition of ARDS? It's hypoxemia due to sudden progressive pulmonary edema with increasing bilateral infiltrates in the lungs. Infiltrates means that there is fluid building up around the lung tissue. And if the fluid is there and it's blocking the gas exchange, you are going to be hypoxic. So cardinal feature is hypoxemia even when we give them 100% oxygen. Now, I'm going to go on a little side note here. We breathe in 21% oxygen, room air. If we're healthy and we're able to breathe appropriately, we are going to have, our oxygen is going to be 21%. 100% pure oxygen is given for those that have hypoxemia. And if they still have hypoxemia with this amount of oxygen, their tissues are not getting oxygen. And what happens when their tissues don't get oxygen? They die off. So this is not good. If anybody worked COVID in the ICU during COVID times, this is what we were seeing. It went from COVID to COVID pneumonia to acute respiratory distress syndrome, and this is why patients were dying. Our patho behind it often occurs with disorders that fill lungs with fluid, which dilutes the surfactant, and therefore the alveoli are eventually going to collapse. Why don't we want the alveoli to collapse? Because there's going to be no gas exchange. Your risk factors for getting ARDS: 3rd to 4th degree burns, tube feeding, being elderly, having aspiration, sepsis, and any kind of trauma. So do not forget that your surfactant is being decreased. There's decreased pulmonary compliance. There's lots of shortness of breath. There's likely an underlying issue causing this response. There's pulmonary infiltrates, or what we call ground glass appearance in when we get a chest X-ray. And then it is highly important for you to remember ARDS equals hypoxemia even when we give them 100% oxygen. So our signs and symptoms will have rapid breathing to shortness of breath. You'll see retractions. They're going to start to turn blue. Heart rate is pounding. ABGs, oxygen is dropping. Shortness of breath is increasing. So how do we manage it? First, hopefully, we catch it in time, and hopefully the patient is going to make it. Early changes of dyspnea and tachypnea results from the alveoli becoming fluid-filled, and that's where the surfactant gets diluted down, and we provide support and oxygen. For fibrosis, increased lung injury causes pulmonary hypertension and fibrosis. That's going to decrease gas exchange. It's going to lead to multi-organ dysfunction because there's not getting oxygen. So we're going to provide oxygen, prevent complications, and support the lungs, and that could be intubation. So we could start up here. Maybe they have some pneumonia. Maybe we put them on the wrong antibiotic. Who knows? Well, more inflammation that occurs, the more fibrosis that is going to happen. The alveoli start to collapse. From there, you're going to have decreased oxygen to the tissues. Hopefully we caught it in time and we get this resolution. It's going to take a while for a full recovery, but after 14 days, it can happen. If no resolution, the patient's likely going to die and have chronic disease. Now think about not having oxygen for an extended period of time. What happens to muscles? They start to break down. What happens to your brain tissue? It starts to break down. So you could have some neurodeficits long term. Now, what causes? How do we get, and I'm going to use COVID pneumonia as the prime example, because if anybody worked during that time, you know that it was terrible. What happened during COVID pneumonia? Well, we have these things called cytokines. Cytokines are like I want to call them like the 911 operators. They are signaling to the police officers to come to the emergency situation and clear it all up. Well, sometimes people have way too many 911 operators or too many cytokines that get activated, and they cause this massive disruption of our immune system. So it causes, when our police officers need to get to a resident, we need the highways open. In other words, we need our vessels open so that our white blood cells and our mast cells can get to that site of infection and clear it out, kill off the bacteria and clear it out. However, when we have too many cytokines calling out the troops, our vessels vasodilate. And then from there, you're going to have massive amounts of immune cells at that site causing lots of congestion. So not only are you vasodilating, causing some hypotension, you're causing further inflammation, and then you have a congested area where you don't have good enough blood flow going to the site, decreased oxygen. And think about this, this is happening in your lungs. You need your bronchioles to have some blood flow, you need to have less congestion to keep it going. So we call this a cytokine storm. When our body has an irregular response or hyperactive response to an issue. It triggers our immune system to flood with inflammatory proteins. And then that severe immune reaction is going to release further cytokines too quickly into the blood. And that's going to continue, it's like a circling effect. It's going to cause breakdown of tissue, inflammation, to the point where your alveoli start to collapse. So a large amount can have the opposite effect of what your body is actually needing, and it can start to kill off tissue. So directive causes of acute respiratory distress syndrome: aspiration. Always utilize your aspiration precautions even if you're not sure, because you'd rather be safe than sorry. Nothing is worse than trying to help your coworker out and not knowing their diet precautions and going in and they ask for water and you give them a thin liquid and then they start to aspirate and choke on it. Well, what's going to happen, especially if it's food, it's going to go get trapped in the lung. Their food is heavily ridden with bacteria and it's just going to keep building there. And now you have aspiration pneumonia on that patient. Can also be a direct lung injury from aspirating gastric contents. So if your patient is a tube feed and you're giving them a tube feed laying down, they could aspirate that tube feed and it end up in their lungs. If your patient has reflux and you lay them flat directly after eating, they could aspirate that gastric contents and the acid into their lungs. That's why we always say reflux and asthma go hand in hand, because when you reflux that gastric acid into the lungs, you get lots of inflammation and that causes the bronchioles to not be able to be completely open. Other causes: near drowning, prolonged inhalation of smoke or corrosive substances, which we'll talk about when we get to burns, infections, pneumonia being one of the top ones, or tuberculosis, and then a pulmonary embolism, or an embolism really anywhere. So indirect causes. So we know it's not directly related to the lung, but because of that injury, now we have cytokine release and now we're having breathing problems. So think sepsis. So your patient that has a sepsis alert, they're releasing their cytokines, their white blood cell count rises, they get fever, inflammation, all that stuff. Well, eventually it could start to affect their respiratory system. Shocked or prolonged hypotension, non-thoracic trauma, having bypassed a CABG, a cardiopulmonary bypass surgery. Head injury, because where's your breathing center and your brain stem? If we have a direct blow to the back of the head, that could cause acute respiratory distress syndrome. Pancreatitis, where we're releasing too much of those enzymes and they start breaking down other tissue. Multiple blood transfusion, we call it a trolley. Diabetic coma, drug ingestion or overdose, and of course infection. So your clinical manifestations. What does acute respiratory distress look like? You're going to have hypoxemia even when you give them 100% oxygen. You could hear crackles, surfactants decrease, fluid is building up. Increased work of breathing. So what does that patient look like? They're probably posturing, maybe hunched over in the tripod position, nasal flaring, retractions, respiratory rate and depth. They'll have rapid breathing, rapid hyperapnea, or it's rapid deep breathing. Chest wall expansion is decreased. Rapid onset of severe shortness of breath, and arterial hypoxemia. So if we put an art line in, their arterial oxygen level is going to be less than 60. Your diagnostics, ABGs. When we talk about lungs, make sure you're getting your ABGs. So hypoxemia, even when they're on 100% oxygen. Arterial hypoxemia. So we put an arterial line in, their number is less than 60. That means they don't have oxygen and they're probably retaining their CO2. They can't breathe it out. So they're going to be respiratory acidosis. Their O2 less than 55. I always say less than 60. while on 100% oxygen, called MD. If their CO2 is rising with this, and then think about what's happening in the kidney. So your respiratory acidosis, they're going to try and pee out get rid of all the acid that way. Chest x-ray, you'll see bilateral infiltrates. I have a nice picture here for you. It's just the cloudy haziness. So anytime you see this, it means there's fluid building up in that lung. Increased alveolar dead space. And then we also want to do a pulmonary function test, which is not going to be so great. It's going to show that their lung compliance is terrible. So what's our medical management of ARDS? And that's going to be an intubation. Anytime we get a diagnosis of acute respiratory distress syndrome, you're to think intubation, because we've tried the 100% oxygen and it's not working. They need to be intubated. Intubation is not only keeping their airway going, but it breathes for the patient, and it kind of takes the responsibility of your own body away so that it has time to calm down and relax. Think about your mechanical ventilators. Positive end expiratory pressure. So if we have pressure when your patient is exhaling, that means that we're trying to keep the alveoli from collapsing. Patient needs help breathing. Always remember, ventilation is never a long-term solution, hopefully, unless you're like ALS or what have you, depending on what the patient wants. In the hospital, there are protocols. Every hospital is different, but for the majority of them, it's like a 2 to 3 week max on a ventilator. They try to wean them off, see how they do. They'll extubate, monitor. This will be up in the ICU, hopefully. And they'll monitor the patient, see how they respond to being extubated. If they can't handle it, they'll re-intubate them. That is because if you stay intubated for a long period of time, you become reliant or dependent on that ventilator to continue to breathe for you. We can prone our patient to improve perfusion and ventilation, circulatory support, adequate fluid volume, and then nutritional support. Making sure, well, we know that we can't feed them by mouth if they've got a ventilator on. So what are we going to do? Probably some TPN. And who's going to help you with that? Your pharmacist and your dietitian. So nursing interventions. Assess those lung sounds and vital signs at least hourly. Suction as needed. Always remember, suction is sterile, and there's protocols that you have to do, which we'll talk about in a little bit. Ensure there's adequate sedation. If your patient is starting to come awake, the first thing that they're going to do is pull out the tube. They're going to extubate themselves. When your patient starts to wake up and they become irritated because they're scared, their cells are like, what is happening? And they become very irritable. Monitor for attention pneumothorax. All that pressure in there could collapse the lung. Nutrition support. Turn every 2 hours. Prone every 2 hours if they tolerate it. Not everyone can tolerate it, especially if they're morbidly obese. But you still need to be moving them as much as possible. So proning is reserved for refractory hypoxemia when they're not responding to other therapies. It's typically done in the early stages. So ARDS in our wrap-up. It is an assault to the pulmonary system. It is respiratory distress. We have decreased lung compliance because you're no longer having gas exchange. The alveoli are collapsing. You have a massive release of inflammatory response, so your cytokines and your white blood cells, your mast cells, and then your surfactant is decreased, and that's going to put you in severe respiratory failure. So a client with ARDS is receiving minimal amounts of IV fluids. The new nurse knows that the client is scheduled to receive a diuretic. The nurse consults the staff development nurse to determine the best course of action. What will this nurse do, the new nurse do? So call the doctor. give the ordered diuretic as scheduled, request an increase in the IV rate, and calculate the client's 24-hour fluid balance. So the answer is B. Research has shown that clients with ARDS may benefit from conservative fluid therapy along with diuretics to maintain fluid balance. The nurse is going to order the diuretic as scheduled. There is no reason to call the doc or request an increase in IV rate. The nurse can calculate the 24-hour fluid balance, but this will not influence the small amount of IV fluids that you're giving. They need minimal amount of fluid. We don't want to increase it. We don't want to decrease it. Nurse is assessing a client suspected of having ARDS. The nurse is confused that although the client appears dyspneic and the oxygen saturation is 88% on 6 liters of oxygen, the client's lungs are clear. What explanation does the senior nurse provide? So we suspect it's ARDS. They are confused, they're short of breath, their oxygen is dropping, even with a high amount of oxygen being given. So is it the client is dehydrated and is too dehydrated for moist sounding lungs? The client hasn't started having any bronchospasms yet. Lung edema in the interstitial tissues, not the airways. Clients with ARDS usually have clear lung sounds. So we need to know why the lungs are clear, and it is C. That fluid is not in the cell and it's not in the vessel. Remember that the alveoli are collapsing, so it's the interstitial space. So lung sounds are going to be clear due to the fact that the edema is found in the lung interstitial tissues. You can hear where you can hear normal breath sounds. It is not related to a client being dehydrated or having bronchospasms. If they're having bronchospasms, you could hear wheezing. The statement about all clients with ARDS having clear lungs does not provide any information. A new nurse asked for an explanation of refractory hypoxemia. What answer by the staff development nurse is best? So what is refractory hypoxemia? Is it chronic hypoxemia that accompanies restrictive airway disease? So that would be like your asthma? No. Think about what refractory means and what does hypoxemia mean. This means that there's no oxygen in the blood and it's because of something else. Hypoxemia from a lung damage due to mechanical ventilation? No. Hypoxemia that continues even after the client is weaned from oxygen? No. So it is hypoxemia that persists even with 100% oxygen administration. Refractory means that it's persisting even though you've implemented tests. Now your mechanical ventilators. I do highly encourage you to watch this video. It gives you like a rundown of why we have ventilators, how they came about. It's very interesting. Okay, so our definition: provide the pulmonary system with mechanical power to maintain physiologic ventilation. What does this mean? That's a lot of big words. So patient's not breathing effectively and we need short-term help. Their lungs aren't working, so we need a machine to do the work for them. And always remember, your ventilator is not supposed to be a long-term solution. It is only short-term because the body becomes dependent on it and it becomes harder to discontinue. It can manipulate pattern and pressures for the purpose of improving efficiency of ventilation or oxygenation. Decreases myocardial workload by decreasing the work of breathing and moving of air. So if your lungs are having problems, your heart is also going to be having problems. Remember, when we're not getting oxygen in through our lungs, our heart's going to be pounding, saying, I'm just going to pump harder and then I'll get oxygen easier to the cells. Well, it's not happening because you're not getting in any oxygen in the lung. And I know this is a lot. I probably should have separated some of this, but when we talk about mechanical ventilation. Intubation and ventilation allow us to bypass natural defenses in the nose and the upper airway. It is sticking a tube into the airway deep down to push air in and push air out. Now, there are different types of ventilators. One is going to allow that patient to continue to have some breaths on their own, and there are some ventilators like your AC ventilator that's going to do 100% of the work for the patient. Now, anytime we stick something foreign into a body, are we at risk for infection? Yes, 100% yes. Doesn't mean that you're always going to have an infection, but it just increases your risk. So you'll have an increased risk for infection. Also think your immune response is being overreactive a lot of time when you go on a ventilator. And now on top of that, you may be on steroids, and that's going to decrease your immune response. All these factors at play. You're in the hospital. These all increase your risk for infection. The longer someone is intubated, the harder it is to remove the ventilator. Emergency intubation. If you find that your patient is lethargic, they're blue, their ABGs are terrible, we can probably assume that there's going to be an emergency intubation. So call the rapid, have the code card, make sure you have suction. You're going to be doing the one with the airbag, so head, tilt, oral, making sure that you have an oral airway or airway established. Give bag valve mask. I have trouble saying bag valve mask, but you have to have a bag valve mask in that room. It does not matter. You have to have it. If that patient's on a ventilator and I'm with you in that hospital, you better know where that bag valve mask is. Oral intubation is fast and easy way to establish an airway. We should know that. We don't use the nasal route. We typically go in through the mouth or the trachea. Ensure that each intubation attempts last no longer than 30 seconds. So right now it's July. We have a lot of residents out there that are learning, rightfully so, learning to be good doctors. So they may need some guidance. So make sure when you're out there that you're helping and saying it's been 30 seconds or it's been 25 seconds. We have to take a break. We got to continue to bag in between. So if it's been 30 seconds, hopefully it's less than 20 or 15 seconds. You're going to say, hey, we got a bag now. We got to provide some oxygen. And that's going to be through the bag valve mask. Suction as necessary. Mark the ET tube. Patient is not going to be able to talk. Hopefully we know that. How do we verify that the tube is in the right place? Remember, when we have that tube, that tube is going to be hooked up to a machine that's going to be forcing air in and forcing air out. So we need to make sure that it's in the right place. It's not like somewhere up in the high bronchial area and putting air into the heart. Who knows? I'm just saying. We just need to make sure that the ET tube is in the right place. So we mark it, get a chest x-ray, make sure it's in the right place. We can also do a CO2 number. The effectiveness of the system depends on the patency of the airway. So the tube must be anchored so it does not slip when the patient moves. Losing an airway can be fatal. If the client develops respiratory distress during ventilation, remove the ventilator and provide breaths by bag valve mask. So, if you do not understand this, bag valve mask, always there. You need to have it. If they're intubating and it's taking too long to establish, more than 30 seconds, you're going to say, time out, we need to give them some breaths. From there, if we find out that the patient looks like they're in respiratory distress after they've been intubated, we are going to remove the ventilator and give them some breaths. So critical rescue. Monitor patients at risk for airway obstruction and impaired ventilation. When you recognize the need for emergency intubation and ventilation, respond by bringing the code, cart, airway equipment box, and suction equipment to the bedside. Maintain a patent airway through positioning or head tilt chin lift and insertion of oral or nasopharyngeal airway until the patient is intubated. Delivering manual breaths with a bag valve mask may also be required. You see here, this is the tube that's going in. We put a cuff in there, a balloon, so it kind of stays there, pushes it in. And this is the tube that the ventilator gets hooked up to. You see there's all different sizes. So action alert. Patients often receive a neuromuscular blocking agent or paralytic agent before intubation to facilitate tube placement into the airway and to minimize risk of aspiration. It also helps calm them down. Despite being chemically paralyzed, patients can hear and feel pain. They can hear everything you're saying. Be mindful. Because paralytics do not have analgesics, amnesic, or sedative properties, it is important to ensure that the patient receives sedation. So, we're going to paralyze and sedate so that we can establish that airway effectively. Assess for tachycardia, hypotension, and tears as possible signs of pain. And that means that they may need a higher dose of their sedation. So your types of ventilators, you have assisted control, you have your AC ventilator. This is the one that you typically see in the hospital. So the machine is controlling everything. It's not synchronized with the patient at all. It is doing all of the work, 100% of the work. Then you have your SIMV or SIMV. It's synchronized intermittent mandatory ventilation. Patients can go home on this ventilator. Typically when we're weaning, we go from AC to SIMV to BiPAP, CPAP. So your SIMV allows the patient to take breaths on their own, and the machine will adjust and continue to pick up the slack where needed. And then you have your CPAP, BiPAP. Your SIMV sometimes can be turned into a CPAP, BiPAP at different modes. This is for spontaneous breathing patients, not for your patient that is in full-on acute respiratory failure. This is continuous partial pressures being forced or by bimodal. Now your care management, respiratory assessments, vital signs, every 4 hours and as needed. So you work in the ICU. This is why I hope that you only have 2 patients in the ICU, because you're doing continuous monitoring on these patients. Some of your patients up in the ICU are going to be on continuous renal replacement therapy with a ventilator, with TPN, all this stuff. So you're going to be doing a lot of assessing. Elevate the head of the bed to at least 30 degrees. Review those vent settings every 8 hours. Make sure that they're appropriate and not too much for the patient. Empty tubing and collecting water chambers. Check for the need of suction every 2 hours. That does not mean that we're suctioning every 2 hours. That just means that we're checking to see if we have a lot of mucus buildup coming up, just the sound of it. That is when you suction, and there is a protocol, which we'll get to. Pre-oxygenate with 100% oxygen before we suction. Turn every 2 hours side to side in semi-prone. Monitor for pressure injuries. Have trach care. If their patient has a tracheostomy, make sure that you're doing trach care. That is a sterile procedure. Trach care needs to be done every 8 hours. You also need to be making sure that you're maintaining some of those mucous membranes so they're not tearing. Assess ABG levels. Make sure you have a pulse oximeter on the patient. Monitor for cardiac arrhythmias. And assess for GI distress. So to prevent bacterial contamination, do not allow moisture and water in the ventilator tubing. So this is why we have to empty it. Your critical rescue. These are the boxes that are in your book. They're high priority. You must know them. Always assess patients being mechanically ventilated for indications of respiratory distress and poor gas exchange. When symptoms of respiratory distress develop on a ventilator, respond by immediately removing the ventilator and having your bag valve mask on hand to give them breaths. This action allows quick determination of whether the problem is the ventilator or the patient. If there is no ventilator problem, reconnect the patient to the ventilator and request respiratory therapy assistance. Now, like I said, sometimes your respiratory therapist is with you. Um, if you've got a big trauma center hospital, a lot of times you will have a respiratory therapist on hand. With those smaller hospitals, you may not. That respiratory therapist is probably 2 to 3 to the whole hospital. So you got to make sure you know what you're doing with these ventilators. Now your controls and settings. Mode, tidal volume, rate, FiO2, your PIP, your PIP, and your PEEP, PEEP. Your mode, that is the way the breath is delivered. So the doctor is the one that decides that. Remember, your SIMV can be put in a CPAP mode. Your doctor is going to decide that. Your doctor is going to say they need to be on an AC ventilator. What is the mode? Tidal volume, amount of air that moves in and out of the lungs with each breath. The rate, the number of breaths the machine is going to take. If it is an SIMV, we know that the patient's making some breaths on their own. It's going to adjust itself. Your FiO2, that's how much of oxygen that is being delivered. Remember, we're at 21% on room air. Now, you can do 100%. It is the fraction of oxygen on inspiration. Your PIP, or peak inspiratory pressure, measure of pressure that is delivered with inhalation. So how much pressure do we push into the lungs to the airway? And then your PEEP is exhaling. How much pressure do we need to maintain in our lungs at any given minute so our alveoli don't collapse? So providing positive pressure in the airway at the end of expiration, it maintains the pressure in the airway at the end of exhaling. It prevents collapsing of the alveoli. These are all the settings and things that you're going to be looking for when that patient's on a ventilator. Now, extubating. Remember, your ventilators are short-term solutions. So when the 2 weeks is up, and it just depends on your hospital protocol, remember. So let's just take that 2-week protocol. 2 weeks is up, we start to wean, we slowly wean them down to where we can extubate them. When we extubate them, monitor those vital signs every 5 minutes. We are going to be looking for respiratory distress. Note that a sore throat and hoarse voice are going to be expected. That is a normal finding. But if a patient has stridor, meaning a high-pitched sound after extubation, what does stridor mean? It means that there's an obstruction in the airway. We're going to give epinephrine and re-intubate. This typically happens when we extubate too early. So sore throat, hoarseness, normal. We're checking those vital signs every 5 minutes. And if we hear stridor, they're probably going to get re-intubated because there's an obstruction. Now your alarms. It is important to know your alarms. But it is more important for you to know that you must not look at your ventilator first. You must look at your patient first. You hear an alarm, you're looking at the patient, not the ventilator. If the cause of the alarm cannot be determined, think patient is not getting oxygen, and that means respiratory distress. The client must be manually bagged with that bag valve mask to maintain oxygen. Always client first, never the ventilator. So, the difference between a high pressure alarm and a low pressure alarm. High pressure means blocked airway or patients biting the tube. That's typically what it means. It could be kinks. Something in the airway is blocked. So psychomotor agitation. It could be biting, could be pain. Assess the client, not the monitor. Assess the client, not the ventilator. Call the doc if there's an obstruction. Low pressure alarm. There's an air leak. There's pressure there. There's still pressure, but there's no obstruction. It's just leaking. So the patient's not getting enough air. Assess the client, not the ventilator. It could be the tube got disconnect. Client may not be breathing. There is a leak somewhere and there's not enough. There's still some air. It's not completely blocked, but they're not getting enough. So low pressure, low air, high pressure, bad news, big blockage. But you're always assessing the patient first. Now your complications: tube obstruction or dislodgement, getting a pneumothorax. Remember, we're putting a lot of pressure in that patient's lung. Could collapse. GI nutrition problems or electrolytes. Several types of trauma. And then our big one that we see quite frequently is our ventilator-associated pneumonia. There are protocols in place to prevent this. So how do we prevent ventilator-associated pneumonia, or VAP? Remove water from the circuits, head of the bed up at 30 degrees, turn every 2 hours. Remember, anytime something is static, things build up. Suction, we're looking for suction every 2 hours. Does not mean that they get suction every 2 hours. Remember, when you suction, you're doing 100% oxygenation prior to suctioning. You only suction for 10 to 12 seconds. Oral care every 12 hours. You're going to percuss, so physiotherapy, loosen up the mucus. GI prophylaxis, remember your body gets physiologically stressed out. Higher cortisol levels come out. Cortisol breaks down your stomach lining, so we want to protect it. Have the patient lying on the side of the good lung. So our suctioning. So most hospitals, this is a great thing, because when I started nursing, we didn't have this. The great thing about suction these days is we have inline suction systems. If you go to the ICU, more than likely we'll see it. There is like tubing around the suction tube. So it helps prevent breakage of sterile technique so that there's less opportunity for infection. Suction should always be sterile. Suction is not applied while the catheter is inserted. Oh dear. So when you're inserting the catheter through the trach, don't hold the suction down. You don't want to do that. That means that you're suctioning while forcing it in. That's not a good idea. You're going to tear up their membranes. Suction should be limited to no longer than 10 to 12 seconds while withdrawing the catheter. Always pre-oxygenate with 100% oxygen for 30 seconds, 3 minutes prior to suctioning. So we're looking at suctioning our patient every 2 hours. We notice that they sound really full of mucus. So we're going to hyperoxygenate for 30 seconds, wait 3 minutes. We're going to put the inline suction in using sterile techniques still, and then we're going to hold the suction down and slowly pull it out for 10 to 12 seconds. Always observe cardiac arrhythmias and report cases of cardiac arrest during suctioning. Remember, you can have your vagal nerve. You can have lots of issues there. Alright, so I charge nurses rounding on several older clients on ventilators in the ICU, whom the nurse identifies as being at high risk for ventilator-associated pneumonia. To reduce this risk, what activity would the nurse delegate to the assisted personnel? Encourage between meal snacks. Oh my gosh, don't do that. Don't feed your patient on a ventilator. No, don't put food in their mouth. It makes my hair stand up. Monitor temp every 4 hours. How often are we doing vital signs? It's every 2. Provide oral care every 4 hours. Report any new onset of cough. Okay. So we're definitely not giving food. No food on a ventilator. They cannot assess your patient. When you go to the ICU, vital signs are pretty much assessing the patient. So that's why you don't see a lot of text in there. Providing oral care, yes, they can give the oral care. They can do that. They can bathe your patient in oral care. But always make sure that you are doing it sometime during your shift so that you can get a complete rundown of what's happening on your patient. Report any new onset of cough. Well, hopefully they can help you with that. Hopefully you're super nice to your tech and they're willing to help you with things and tell you about things about your patient. But honestly, you need to be assessing your patient for that cough. So the answer is C. They can do that oral care. An intubated client's oxygen saturation has dropped to 88%. What action by the nurse takes priority? So, they're intubated, their stats are dropping. Do we want to determine if the tube is kinked? Ensure that all connections are patent? Listen to the client's lung sounds? Or section the endotracheal tube? So we know that we can cross this off. Least invasive first. We're not just going to say, oh, maybe they need suction and cross it off. No, we're not doing that. Listen to the client's lung sounds? Absolutely. What's happening in those lungs? Why is it dropping? And always assess that patient first. These mean that you're not looking at the patient first. Determine if the tubing is kinked or that all connections are good. You need to look at your patient first and assess them. And then if you hear lots of mucus, that's a crackly stuff happening, you can give them some suction. Or maybe if you hear that low pressure sound and the client's lungs are clear, you could probably make sure that nothing is kinked. A client is on a mechanical ventilator and the client's spouse wonders why ranitidine, which we don't use anymore, is needed since the client only has lung problems. That's your Zantac. So why are we giving Zantac to a patient that only has lung problems that's on a mechanical ventilator? So what do we say to that spouse? It will increase the motility of the GI tract? No. Zantac ranitidine is an H2 blocker. It is going to decrease acid. Why do we have a buildup of acid? And concern for peptic ulcers? Because cortisol is being released. It will keep the GI tract functioning normally. No, I mean, it doesn't take over the GI tract. It just helps with the acid and breakdown of the tissues. It will repair the GI tract for enteral feedings. No, that doesn't do that. It will prevent ulcers from the stress of the mechanical ventilation. Absolutely, stress ulcers. H2 blocker. All right, going into our chest trauma. So what is chest trauma? We all know what chest trauma is. You get in a motor vehicle accident, the airbag gives you blunt force trauma. You are a football player, you get plowed over in the field by a 400-pound man. Chest trauma. You are an MMA fighter. You get punched in the ribs too many times, now you got some fractures. So it could be pulmonary contusion, which is a bruise, a flail chest, which only happens when you have rib fractures. Could be a pneumothorax, could be a tension pneumothorax, so this is always with tension for trauma happened, or a hemothorax, think gunshot wound. So with our chest traumas, our priority is always airway, breathing, circulation. You want to try to get a who, what, where, when assessment of what happened. Sometimes that's not always a thing though. Do a 1-minute assessment. Look for shortness of breath, get your vital signs, look at their skin color. Is it turning blue? Is it pale? Is it mottling? Look at their temperature. Are they cool to touch? Those are important. Those tell you a lot right off the bat. Is there a wound somewhere? Is that why they can't breathe? Is there a wound specifically penetrating their chest area? Is it because they are in septic shock and they have cytokine storming and going to acute respiratory distress? Do they have jugular vein distension, paradoxical respirations, meaning their chest is sinking in and their stomach is pushed out? Stridor, is there an obstruction? Tracheal deviation. We'll see that a lot with your pneumothorax, where the trach and the mediastinum shift to the opposite side. Do they have bilateral breath sounds? Are they missing breath sounds on one side? Do they have chest wall movement symmetrically? If one of the side of the chest is not moving, that's a big problem. And are they using their accessory muscles to breathe? And then, of course, monitor your heart, get those sounds in, and look for dysrhythmias, and check your pulses. So, pulmonary contusion, it is a bruise. You rupture those capillary beds, and that is a bruise. It could be from a rib fracture. Maybe you get hit really hard in the chest and it fractures one of your ribs. You're going to have some bruising there. Very common in blunt force thoracic trauma. It could be lethal, depending how deep the penetration is. Respiratory failure develops over time. You could have some hemorrhaging, edema in the lungs. You're going to look for hypoxia and shortness of breath, maybe coughing up blood, hemoptysis, crackles, wheezing, decreased sounds. Crackles and wheezings, blood is filling up, airways getting blocked, inflammation is occurring, and if they come in with that and then you have no sounds, it's a big problem. This patient could be put on a mechanical vent, and there are some of course we're going to do all the protocols with the ventilator. Your flail chest patient. This happens with rib fractures, 2 or more rib fractures, and that's going to cause a paradoxical movement of the chest. So they breathe in and the chest sinks. They breathe out, the chest expands. The patho behind it can lead to a problem with inhalation due to chest wall moving in the opposite movements. The findings that you're going to see decreased tidal volume or air going in, decreased ability to cough, hypoventilation, shallow breathing. Not only is it because there's penetration there, but it's also because it hurts to breathe. Paradoxical chest wall movement, a portion of the lung deflates during inspiration, and that's not normal. Involves the lateral side of the chest, and you will see mediastinal deviation. So you got that mediastinum, it's going to move to the other side. Anytime you see that breastbone moving to the other side and your trachea also moving to the other side, there's something wrong with your lung. It is bad news. So some complications that can occur, of course we know that the patient can die, but you'll see atelectasis, which is collapsing of the alveoli lung, pulmonary edema, and respiratory failure. Other complications of the chest wall, pneumothorax or hemothorax. So we have that pleural space. Remember we talked about that pleural effusion? We get lots of fluid buildup. Well, a pneumothorax could be air or blood in that pleural space. So hemothorax is the blood. It is ultimately going to change the pressure in that space, and it's going to decrease surface area for gas or oxygen exchange. It collapses the lungs, in other words. Pneumothorax could be open or closed. So if it is open, think that there's an outside source. I always think of like a stabbing in the chest wall. Someone stabbed somebody in the chest. Someone got a gunshot wound to the chest. Something punctured you from the outside and has now caused the deflation of your lung. So open, you will hear a sucking sound. Air goes in and then it gets trapped. It's likely from a gunshot, a knife, some type of impalement. Abnormal movement of air through the chest wound. So air, when the person breathes in, the air is going in. It's going in through the wound. The problem is it gets trapped there. It doesn't exit. So wound needs to be covered because more air will continue to go in with each breath. and you want to cover it with a sterile bandage. Now, a closed chest wall, so a closed pneumothorax. Air enters the space when inhaling but does not move out as well, but it's not moving in through the wound. You're breathing in, it stays there. Chest wall remains intact. The patient is likely going to need a central line. Now, your spontaneous pneumothorax. There's no obvious reason. There are some risk factors that could occur. Think about your scuba divers, especially living in the south near the water. If any of you scuba dive, you know that you cannot go up if you're deep down in the water, you cannot go up real fast to the surface, because that will give you a spontaneous pneumothorax. The pressure changes so much that it's going to collapse your lung. Think about mountain climbing. We'll get more into that high altitude sickness and whatnot when we get further into the quarter, but when atmospheric pressures change, it's also going to play a big role in the pressure in your lungs, your chest wall. So maintaining the pressures, the atmospheric pressures at a slow change, changing them slowly, is going to allow you to acclimate before anything bad happens. Issues with lungs from illnesses or injury due to smoking. These can also cause problems. Menopausal women can also be at a high risk for spontaneous pneumothorax. Ultimately, it's idiopathic. We don't know. There's no obvious reason, but there are risk factors. I have added a scene from this movie, Just Like Heaven, where she thinks she's a doctor and there's a waiter that collapses and he had a tension pneumothorax. So our clinical manifestation. Always remember pneumothorax, any chest injury that allows air into that pleural space and collapses the lung. Your clinical manifestation, you're going to see absent breath sounds on that affected side. You're going to hear hyperresonance, dull sounds. Remember, anything dull means that there's air or fluid. Tracheal mediastinal deviation to the unaffected side. So let's say you have a pneumothorax on the left side. So your left lung has collapsed. Well, all that air pressure building up in that pleural space is going to push your heart, your breastbone, your trachea to the right side. That's never a good scenario. Patient is going to have poor respiration. So they could have subacute emphysema, so the crepitus, and fast breathing. For your tension pneumothorax, tension for trauma, air moves in but does not move out and is likely from blunt force trauma. The lung gets smaller and smaller. It's going to cause a deviation to the thoracic organs and everything shifts to the opposite side. You can also see jugular vein distension because the heart's being pushed to the other side. So the blood flow into the heart's having some issues. It's going to start to back up. Clinical manifestation, extreme respiratory distress, tracheal deviation, mediastinal deviation, distended neck veins or JVD, absence of breath sounds on the affected side. This is a good picture. So we get tension pneumothorax. We see that the mediastinum is starting to deviate. We also see the heart structure starting to deviate. So that means that blood flow can't get into the heart as well. Things are getting squeezed on this side. So fluid is going to start to build up and cause GVD. Some questions. A client in the ED has several broken ribs and reports severe pain. What care measures will best promote comfort? Is it giving them a nerve block, humidifying supplemental oxygen, giving them a ACE wrap around their chest to splint them, or providing them warm blankets and warm IV fluids? So several broken ribs. The answer is a nerve block to help with the pain so that they continue to breathe. Yes, we probably are going to splint the chest, but the nerve block would be the best. A client is brought to the ED after sustaining injuries in a severe car crash. The client's chest wall does not appear to be moving normally with respirations. Oxygen saturation is 82% and the client is cyanotic. What action does the nurse take first? Administer O2 and reassess? Oh no. Well, okay, so we've already assessed. Auscultate the lung sounds? I mean, yeah, but that wouldn't be our priority. It's obvious that they're not breathing. They're cyanotic, their saturations are dropping, and they're not moving normally. Facilitate a portable chest x-ray. I mean, we would, but our priority would be assisting with intubation, getting everything ready, having your bag, valve, mask, your crash cart, all of this stuff ready. Because it looks like they're not breathing, and their things are dropping pretty quickly. All right, so chest tubes. Hopefully, like I said, hopefully you guys are being able to see chest tubes in clinical, but also being able to mess around with them in lab. The whole purpose of a chest tube is to reinflate the lung and drain whatever is in there out. The tube is in the pleural space. You can have a water-sealed chest tube drainage system, and it could also be hooked up to suction. Water seal means that we have a seal that allows the pressures to pull the fluid out. So the water seal prevents backflow into that pleural space. You have to have 2 centimeters of water at minimum to create that water seal to prevent the airflow from going back into the lung. Check the water seal every shift. The water needs to be sterile and at the level indicated, 2 centimeters. If you see continuous bubbling in that water seal chamber, that is bad news. That means that the seal has been broken and airflow is going back into the chest. The whole point is to remove air or fluid, and it is priority. If on your shift you have a chest tube that is getting 70 mLs or more an hour of drainage, you need to call the doctor. That is too much. Something is happening. Check the tube placement with each shift. Never strip or milk the chest tube. You're going to milk the chest tube. You're never going to take your hand and just pull. Let's say that there's some drainage in that tube. You're never going to start at where the chest tube is placed on the patient and just continuing to pull to get that drainage into the the device. You're going to do a hand over hand milking demonstration on that. So it's not pulling the chest tube out of the patient or not dislodging it. So when do we notify the doctor? If we notice tracheal deviation, that means that the chest tube probably got dislodged and now they have air trapping or blood trapping, whatever, some kind of fluid trapping or air, and you're back at stage 1. So it got dislodged. Sudden or increased dyspnea. An O2 stat less than 90%. Drainage greater than 70 mLs an hour. Let me say that again. Drainage of 70 mLs or more an hour. Visible eyelets. If the chest tube falls out, you need to you're not going to reinsert it. If you see nurses reinserting it, I'll just gasp. Don't do that, because if it's coming out, that means it's no longer sterile, and you may not be putting it back into the pleural space appropriately. So if it falls out, you're going to cover the site with sterile dressing or sterile gauze, and of course it needs to probably be reinserted. It'll be up to the doctor. You're going to call the doc if it disconnects, if drainage stops. So if you have too much drainage or you have no drainage, call the doctor. Now, this is your suction chamber. This is your chest tube device. This is your water seal chamber. This is where, I'm sorry, no, this is your water seal chamber. This is where, they all look different. There needs to be no bubbling in this. You need to have 2 centimeters of sterile water. You need to check it every shift. This suction chamber can have some bubbling. If you have it hooked up to suction, you can have some bubbling there, but not in the water seal. We do the water seal. If it's bubbling, that means there's a leak. We are monitoring this side. So let's say you get on shift at 7 o'clock, and by 8 o'clock, your drainage appears at 100 mLs. What are you doing? You're calling the doctor. So your question: while assessing a client who is 12 hours post-op after a thoracotomy for lung cancer, a nurse notices that the chest tube is dislodged. What do you do? Assess for drainage from the site, cover the site with sterile gauze, contact the doctor, reinsert the tubing. Well, we automatically know if the chest tube gets dislodged, we are not reinserting. We are probably going to call the doctor, but our first priority is cover that site with sterile gauze. Remember, you have that open wound, you breathe in, air is going into that pleural space. It's going to get stuck there, so it is going to cause a pneumothorax. A nurse cares for a client who had a chest tube placed 6 hours ago and refuses to take a deep breath because of pain. What action would the nurse take? Ambulate the client in the hallway? Well, they have a chest tube and they don't want to breathe because they're in so much pain. We're not getting them up. Auscultate the client's anterior and posterior lung sounds? Yeah, we would do that, but what is our priority? Encourage the client to take shallow breaths to help with the pain. We never encourage just shallow breathing. Administer pain meds and encourage the client to take deep breaths. Absolutely. They need to take deep breaths, but in order to do that, they probably need some pain medication. The nurse cares for a client who has pleural chest tube. What action would the nurse take to ensure safe use of equipment? Strip the tubing? We know that's wrong. Secure tubing junctions with clamps to prevent accidental disconnect. We never clamp it unless it gets disconnected, so nope. Connect the chest tube to wall section as prescribed by the primary healthcare provider. No. Keep padded clamps. Yes. This is important. Keep padded clamps at the bedside for use if the drainage system gets interrupted. The nurse assesses a client who has a mediastinal chest tube. Which symptoms require the nurse's immediate intervention? Select all that apply. So mediastinal chest tube, what is our immediate intervention for assessment? Production of pink sputum? Oh yes, this is bad. Tracheal deviation, absolutely. Pain at insertion site, that would be pretty normal. Sudden onset of shortness of breath, yes, absolutely. Drainage greater than 70 mLs an hour, oh yes, we always call the doctor for that. And then disconnecting at the Y site, yep, any disconnection. So immediate intervention with our assessment is going to be B, tracheal deviation. D, sudden onset of shortness of breath. That means it's probably dislodged in the wrong place. Drainage, lots of drainage, that's bad. And disconnection is bad as well. And that is it.